Um, so thank you for the segue, Kate. I think in the midst of all of us working extremely hard clinically to try to take care of these patients, we did find some interesting research opportunities. So, as Cappy and Kate already alluded to, the major clinical problem as neurointensivists was that we couldn't monitor these patients who were sedated and paralyzed. They were often extremely unstable on dialysis and ventilators and inhaled medications. And so they were not easy to move for imaging. And we were really trying to limit the people going into the room. And so we very much limited conventional EEG on these patients because that requires a tech to be up by the head of the bed for almost an hour. And so, there really was almost no monitoring of these patients until we lifted sedation and kind of crossed our fingers and hoped that patients woke up. One option that I'm sure the vascular neurosurgeons are very familiar with is the transcranial Doppler. So that's a really useful bedside tool, which we usually use in subarachnoid hemorrhage to look for vasospasm, but there are a lot of other abnormalities that we can detect on this sort of imaging. The problem is that similar to EEG, if you're doing transcranial Dopplers, this requires that there is the person who's performing it is by the head of the bed and manually looking for the signal. We had worked with Neural Analytics, which is a company that makes our Lucid system, which is our transcranial Doppler system. And they had this really neat robot that basically, takes the probes, optimizes the probe placement, finds the window, and then is able to acquire and maintain the signal over time. The idea of an automated Doppler system was particularly attractive in the COVID population because this really allows you to minimize the amount of time that you are in the room and at the head of the bed near the patient. And so, I won't do this system any justice, but using machine learning, this algorithm responds to the data that it's receiving and then searches for the optimal signal. And it responds to this data just like a human tech does, and much better than I do at the bedside. And so we thought that this was a really interesting opportunity to use this machine in order to monitor patients. And so thanks to a great partnership with Neural Analytics, we were able to have a robot sent to us on loan. And even more importantly, we had 2 people sent to us on loan. On the left is Kat DeSantis, and on the right is Joshua Renz. And they actually both volunteered to come to the epicenter of COVID in New York City and help us with using this machine on COVID patients. So you can see on the right, John Liang and I worked with them to identify appropriate patients who were sedated, paralyzed, or not waking up after sedation was held as a pilot project to see if there were any abnormalities that we could detect. And this is a project that's ongoing. I'll just show you a couple of things that we've noted so far. So, these are normal transcranial Dopplers. So you can see there's a triphasic wave. These are waveforms that were obtained in a study looking actually to identify large vessel occlusion. And so you can see, there's a lot of nuance, obviously, but you can see that the waveforms become blunted, that the velocities drop on one side when there's a large vessel occlusion. And the normal triphasic morphology goes away somewhat because of the blunting. These are examples of some of the patients that we have scanned with COVID-19. On the left, you can see 2 sets of waveforms that are somewhat normal. They have the triphasic morphology at least. We'll say that the velocities on the top are a little elevated. But on the right, what you can see is some very abnormal waveforms. They suggest high resistance, and the waveform morphology goes away. It's a little hard to tell exactly what these waveforms mean. I think we need a little bit more data. These are just 5 examples of patients that we scanned. Again, you know, their exams were all kind of non-focal, just severe encephalopathy for the ones who were off sedation, or patients with no exam except a pupillary exam because they were paralyzed. I think the trend that we've seen are these highly resistive waveforms, and that could be for a couple of different reasons, which we still have to kind of work out. So these patients often have changes in their CO2 if they're not being able to be ventilated, and that can result in cerebral edema. We don't know if these patients have undiagnosed intracranial processes because these patients are unstable to move for traditional imaging. There may be a distal vasculopathy in some of these patients. You know, we do know that there's evidence of vasculopathy in other organ systems in this disease process. And then last, we don't know whether these patients have appropriate autoregulation or not. But we have also noted several patients with asymmetries in their waveforms, even though there's no clear asymmetry in the exam that we're able to obtain. So I think there's kind of a lot that we can look into here. Another nice study that you can do on transcranial Dopplers is looking for high intensity transient signals. So this is the so-called HIT study that is very common to do on the stroke side. But basically what you're doing is you're insunating the blood vessels and looking for spontaneous emboli. So in the patients that we scanned, we looked for these high intensity transient signals. We do know there's a higher risk of stroke in these patients, and at first, we weren't sure whether these patients may have embolic phenomenon. There is cardiac involvement, and these patients do develop some arrhythmias. And so, you know, we wondered whether we were going to be seeing any of these abnormal signals suggesting spontaneous emboli. We did this in patients who were both on and off anticoagulation. We specifically looked for patients who had a reason to be off anticoagulation, such as, you know, recurrent GI bleeding. And we knew that in several of these patients, they were prone to clotting. Every time they had a line placed, it was immediately clotted. But surprisingly, we scanned 23 patients with no evidence of any spontaneous emboli. So I think, you know, even this negative information is kind of helpful for us to be able to understand the pathophysiology of the clotting that's going on in these patients. I think one of the most interesting options for this robot is that it's a continuous monitor. So unlike a transcranial Doppler that's done by a tech or by one of the providers at the bedside, this robot can stay on the person's head for as long as you want it to be. This is an example in a case that we collaborated with the company on before COVID hit. This was a patient who had cerebral edema. And Dr. Riley was at the bedside and pushed hypertonic saline. And you can actually watch over the course of 20 minutes what happens as you push the hypertonic saline. The velocities are on the top, and the pulsatility index, which is an indirect measure of the intracranial pressure, is at the bottom. And so what you can see is that at the beginning, the pulsatility index is quite high, suggesting cerebral edema. As the hypertonic saline is pushed, you can see a drop. That's the orange signal. Both on the left and the right, you see a drop. And with the drop, you see a delay in the drop of the velocity in the brain. And that's actually suggesting that there's a drop in the arterial pressure, which we often see with a push in hypertonic saline. And so as the blood pressure drops, you then actually see a rebound increase in the pulsatility index due to autoregulation. and vasodilation. And then that slowly improves over time. And so this continuous monitor is actually, at the bedside, where we routinely will push this with either an ICP monitor in place, or if the patient does not have an ICP monitor, then we're just monitoring the pupils. If you have a continuous TCD, you're actually able to monitor in real time what's going on in the brain. This was another study that we collaborated on them with. This was a patient who unfortunately was progressing to brain death despite maximal medical treatment. And so over time, you can see the analysis of the waveforms. On the left in cluster 1 and 2, you start to see changes in the waveforms with increasing resistance. And then the waveform below that actually shows negative flow is actually showing you the what ends up becoming pendular flow during brain death, where you have no net forward flow. And so you have both forward flow during systole, and then reverse flow during both systole and diastole. And so using this sort of machine learning to understand what's going on in the waveforms can be really helpful in trying to understand what's going on intracranially, particularly in these patients that we can't monitor any other way. So we've been really lucky to be able to work with Robert Hamilton and the entire team at Neural Analytics to come up with some projects. We're actually working on some grants as well. And to our knowledge, we're the only institution in the world right now that has access to this team and is using continuous TCDs to be monitoring patients with COVID-19. And so some of the projects we're looking into are feasibility of monitoring patients who are on anticoagulation. As Cappy mentioned, we're often just hearing about these patients once they've blown a pupil. And presumably, if you could detect these patients earlier and stop and reverse anticoagulation, we may not have as many deaths from ICH. We want to look into mechanisms of stroke in COVID-19. And then we're hoping to work with our Moberg team to evaluate cerebral autoregulation using both blood pressure, continuous blood pressure monitoring, and continuous TCD monitoring to be able to understand whether the autoregulation in the brain is actually normal or abnormal, and whether we can try to target certain physiological variables in order to normalize autoregulation in these patients. Because we know that even if they do wake up, a lot of them are waking up with encephalopathy, and we don't really know what that's from. And so it may be that the abnormal autoregulation is actually causing neuronal injury during the acute phase. And we have an exciting collaboration with our pulmonary team as well. We have a paper that's being reviewed right now, and hopefully we'll be able to show you some more data sometime soon. And so with that, I'm going to stop sharing my screen and hand it